My name is Jacqui Richmond. I'm a nurse and work as a program manager at the Burnett Institute, and I work on a national hepatitis C elimination project called Eliminate Hep C Australia. I have colleagues. These colleagues are all going to introduce themselves as part of the forum. And we do have a clicker. Emily Adamson.
Hi everybody, I'm Emily Adamson and I also work at the Burnett Institute with Jacqui, also on the National Eliminate C program, and my area is health promotion and community-led programs. Great to be here this morning.
Alex?
I'm Alex Way. I am a clinical nurse consultant in hepatology and I look after a team of amazing Hep C nurses and work with our NSP under public health. And I'm from New South Wales, Australia, and that's it.
This is a true collaboration, and I know I speak on behalf of my co-authors from Australia when I'd like to say that we all work on unceded lands of Aboriginal and Torres Strait Islander people. For me, I work on the lands of the Wurundjeri people of the Kulin Nation. The Burnett office is the Bunurong people of the Kulin Nation, and we all acknowledge elders past, present and emerging. So I was hoping to get the slides up because that would then show that how truly collaborative we're being, because we've also enrolled the support of our UK colleagues. Thank you very much to Louise for connecting us. So this work has come about, I guess, peer nurse partnerships. We feel we can't do Hep C elimination without peer nurse partnerships, and it has originally stemmed from work that Emily and Jane and Sally all led through a health promotion campaign. So what we want to do today is give you some examples of peer nurse partnerships. So we're going to start firstly with the Australian experience, and then we're going to pass over to James and Cy. Even though Julian is listed,
If he shows up, I'll...
Oh, no, I want you now. Sorry. No, you're here with us. And then we're going to do some workshop discussions. So if I could have the slides, that would be really helpful, because at the moment I can't. But off the top of my head, here we go. So this is our collaborative team, and we're going to... First of all, I just wanted to say we've been thinking that potentially there could be a commentary piece on peer nurse partnerships that could evolve from this work. So we've sought advice from an ethics committee, and they have advised us that we don't need ethics approval, but we did need to let you know that we might be using some of the themes. So there won't be any identifiable information or examples included in a commentary, but we just feel it's really important to get this topic out there and to start talking about it. So I will not go there just yet, but we will have 3 workshop discussions. One is about scope of practice and that interaction between peer and nurse and the skill mix that's required for both. The second topic will be around data collection for both peers and nurses. What are best practice models, listening to what people think and what's working and what's not working. And the third one is interagency collaboration. What we see here in Australia is we often have peers and nurses who are working for different organisations coming together to develop that partnership to deliver care closer to where people are living and want to access that care. So we want to have some discussions around that. But I'm going to first start by asking Jane and Sally to introduce themselves and to give us a bit of an overview of your model.
Good morning, everybody. I'm Jane. I work for Harm Reduction Victoria, which is a drug user organisation in the state of Victoria, Australia. And I had the pleasure of partnering with a wonderful nurse here, Sally, who I will pass over to introduce herself.
Pay you later, Jane. Hi, everyone. My name's Sally Watkinson. I'm a nurse practitioner. I work in 2 roles. One is outreach in a viral hepatitis testing and treatment role with Jane, and my other role is in drug and alcohol in a pharmacotherapy outpatient service.
Okay, so Yeah, it's all right to feel all right. This campaign was a long time coming. It was co-designed by a bunch of nationwide, not just in Victoria. It was nationwide. A whole bunch of peers and the Burnett Institute, and we tested messages that we thought were suitable for our community, and It's Your Right to Feel All Right was the winning one that came up, and they were really vibrant, colourful messages, and there was a huge advertising burst. It was on trains and buses and billboards, and there were stickers, and you know, the back of the toilet door, what you sit and read when you're in there. Everyone looks at those, don't they? But no, there was. It was very visible, and as you can see, they're really colourful, and they're messages that we thought related to peers. My favourite one, to get clear while on gear, because so many people thought that you couldn't access treatment while you were still using, and this campaign really dispelled that myth. I thought it did anyway, but it was really well received, and Burnett actually did evaluations afterwards, and it was seen everywhere, wasn't it? Yeah. So yeah, that was those, and it was. We went back and forth with messages before we came up with those, but I think we landed with the right ones because it seemed to hit the spot.
Thanks,
Yeah.
Jane. So, how do I do this?
Big green button.
Big green button. Thank you. Yeah. So, Jane and I had worked together on a number of projects over the years, but the It's Your Right campaign really kind of solidified our working partnership, didn't it, between our two organisations. My organisation is a large tertiary hospital. I work for the Infectious Diseases Service there. And Jane, as she says, works for Harm Reduction Victoria. And part of the It's Your Right campaign funding enabled us to start doing outreach in a suburb of Melbourne, which is where we are, called St Albans, and this suburb is a low socioeconomic, outer suburban suburb with a reasonably active street-based drug scene. And so what we did was we borrowed a vehicle, a van, from the Burnett Institute, and we just started, basically. We just found a suitable location. There was a community hall called the Tin Shed, which had been established many, many years ago, so it was well known within the community. It was conveniently right in between the train station and the local most significant drug dealers' premises. So we would either catch people on the way there or on the way back. And we would park out there once a week on a day when there was also a food bank there. So there was lots of bustling around and lots of people attending that service. So there's Jane and I sort of running this project, if you like, but we're also working closely with peers that were fairly new to the organisation, who had shown an interest in this kind of work, that also very much were local to that area. So they knew the local community, and I think that was one of the most critical things about how this worked, was that it wasn't just any peer that was working on this project, it was a peer that really knew the community that we were trying to engage with. Can't quite see what I'm reading here, but so how did we work? Well, I think we just had a fairly informal approach to this. We just kind of went out there and did it. But I was trying to think about how that actually played out when I was just putting this slide together, and just thinking, well, it was really quite organic. We just sort of slotted into each other's roles, really, didn't we? I think critical to that has been that there's no one in charge. It's like we have our skills and we have our areas of expertise, and we've learnt from each other. We both respect each other very, very much. I've learned so much about the community that we're caring for just by sitting and listening to Jane and the other peers. And it's obvious to us that we're all really committed to do this kind of work and actually reach people that haven't been reached by health services in the past. Excuse me, peering over. So we don't have any specific funding to do this, although we did have some as part of the It's Your Right campaign to provide some reimbursements for people getting tested for their time and for coming to have a test, and we found that really, really helpful in engaging the community. We are still borrowing that vehicle, and we've moved on to another site now, but it's a little bit unstable as to how long and when we might get access to that vehicle, so that's one of the challenges that we have. And obviously, peers and nurses don't grow on trees, so especially ones that are so well connected within the community. So we're always looking for, people that come to us and get tested that might be interested in learning to do this work as well. So as I said, we've moved, we've tested, we tested in a period that has been evaluated so far about 200 people. We're just there for a couple of hours a week over an 8-month period, and we treated about 20 people for hepatitis C over that time that weren't aware of their diagnosis previously. Some incidental other findings of hepatitis B and other health conditions that we needed to address. And yet, we're still going, we're just doing our thing. We're considering introducing point of care testing. We're considering a regional model, or at least Harm Reduction Victoria is at this stage, and we'd be happy to be involved. And yeah, always looking at where the next place to go is, so adapting to the needs of the community, really. That's us.
And I know we've just hit time, but can I just add, we were doing venous blood draws out there. We were only out there for a few hours each week, and it was phenomenal the number of people that we ended up getting through, I think anyway.
Yeah.
Because originally Sally said, well, I like to spend about at least 30 minutes with each person, speaking to them before I take their blood. And I'm thinking, God, if we're only going to be out there for a few hours, how many people we're going to get? But we worked her to the bone. And we got lots of people. So, yeah, thank you.
Thank you very much, Jane and Sally. Are there any quick questions? Julian? You might need to use your big voice, because oh, yes?
Just a quick question. You said you've not got any funding, but are you paid, or are you just doing it out of the kindness of your heart? I'm quite interested with Find the Treat. We're going to introduce ourselves. Can you hear me, or I hate that? Like, sometimes, so my name's Julian, I work with the Find the Treat team, UCLH, which is NHS Trust in the UK. And it's sometimes about the funding. It's like I'm very conscious, we often say peer-led. I think very few of our interventions are actually truly peer-led. They tend to be on the lower bands, lower paid, entry-level jobs, and we've really tried hard to get our guys up to level of either at nurse level or experienced nurse level, and they should be paid appropriately. But I think sometimes the funding is really tight, we know that. I was just wondering, you said you don't have any specific funding. You just like being a bit cheeky and borrowing stuff? You paid, or what's the deal, basically?
Yeah. We were getting money from other parts of the program, and that I'm employed like full-time and on a wage, and the peers, to be honest, they begged to do it. They wanted to do it for nothing, and I wouldn't have them do it for nothing just for that exact reason. But they came, and I think we reimbursed them enough, and they didn't have any extra responsibilities. All their job was to turn up and talk to their mates, and they were like impressed with how much they got paid. They were out there for a couple of hours, and they'd usually go away with $100, so they were quite happy with that. And that was under the table pay, it wasn't on the books.
Australian Government Taxation Office is not here. hopefully. Thank you very much. And it's a great question, Julian, because, yes, I think all of us put in the extra effort, but we need to be reimbursed for our time. Absolutely. So, yeah, it's just about not having that specific funding to really scale this model up as much as it could. So we are now going to invite our new friends from Find and Treat, NHS, and we've actually got Cy, because Julian was too scared. Yeah. So, and James. So take it away.
Brilliant.
Thank you, you two.
Hi, I'm Sive. I'm one of the inclusion health nurses on the Find and Treat team. That's our glorious leader over there, who is supposed to be up here. But so Find and Treat is a pan-London service. We have 2 mobile health units. One does predominantly TB x-rays and vaccinations. And then the smaller van that I work on with these guys does bloodborne virus and STI testing. So kind of echoing what you guys were saying, like, I don't think there's a particular model that we necessarily follow. I think it's the reason it works is because who we all are as individuals. And I think there's a mutual respect there. We get on, we have fun together. And I think that's why it works. And I think like any other relationship, you know, sometimes it works and sometimes it doesn't. The same way that like I could have a good relationship with another nurse or another doctor. I don't think there's necessarily like a specific thing that we do that make it work per se. I think mutual respect is probably the biggest thing. I think as clinicians we can tend to be quite gatekeepy, but within Find and Treat I don't think there is that. Like most of the skills that I utilise on a day-to-day basis is stuff that I've learned since joining the team, not that I've learned in nursing school. So there's no reason why James or John or the other peers on the team can't do the same thing that I do for the most part.
Absolutely, yeah. Hi, yeah. Oh, let's bring it a bit closer. Yeah, my name's James Rocker. I work for the Hepatitis C Trust. I'm a Pan-London peer program manager. And yeah, just like what Si was saying, pretty much I do day-to-day, I do the nursey stuff really. So I'm trained phlebotomist. Do you know, I feel pretty privileged at Find and Treat because we're allowed full access to patient records for spine, digital outreach, which is great. We can take venous bloods and do medical and social assessments. We get lists from ED and loss to follow-up, which John leads, which I'm doing at the moment in South London. And we contact patients and we ask for consent and we home visit in the van. And we do these medical and social assessments and then we do the MDT referrals, but you know, it's always under, you know, any decisions made are done by a clinician or clinical. So, but yeah, it's really good. I coordinate the van as well, the BBV van, which we do all over London. Hostel testing. We do more targeted outreach testing as well. We do sort of services, drug services as well, which is great. We've got a mobile bike as well, which has a bed on the back, a FibroScan. It's pretty advanced. It's run by solar panels. It's a pop-out clinic as well with a 10, which is great. It's good for London, which is brilliant. And yeah, just sending referrals to mainly just the linkage to care really to local ODNs and sending bloods to labs and sending lab reports and getting people through treatment and supporting people through treatment as well, which is great. But yeah, it's an absolute honour really to work for the NHS, especially with my own lived experience of having Hep C multiple times. I was, you know, person who used to inject drugs and I've had TB as well. Most of the time when I am working, when I'm sort of giving my lived experiences, mainly usually when I'm actually street outreach based, just really quickly to gauge, you know, to get trust quite quickly, you know, when people are on the streets. But most of the time when I'm doing a lot of the loss to follow-up and ED work, I have my, you know, really have to have my professional hat on. So, yeah. But
just to add as well, I think one of the things that works the NHS is the National Health Service in the UK. Most of the peers, James is now employed by the NHS and John is employed by the NHS, but most of the peers come from the Hep C Trust, which I think works quite well because there's a lot more pastoral care than necessarily there is in the NHS, and I think that's something to look at in terms of like trying to have like this perfect model. I think there has to be more, and it's not just for peers. I think for nurses, for anyone, like there should be more pastoral care that doesn't really exist within the NHS. Like, yes, you can go and ask for help, but it's not necessarily like provided to you. Whereas with the Hep C Trust, they have to do clinical supervision, and it's part of like part of your within the job, like you have to do it, right?
Yeah, absolutely. Great support, with the Hep C Trust clinical supervision and supervision as well. And it's great. And the best bit about my job is actually sort of training and skilling up volunteers as well, and peer workers, which is a great part of our organisation. And we've got a good linkage to care with prisons and in the community, where we've got our own system where we can follow up patients in the community, and as well we've got the NHS as well, where we can have the leads of the nurses into the prisons and find out if people are there as well, which is great. So it's nice to have the best of both worlds, really, which is great. Yeah.
Fabulous. Thank you very much. Everywhere we go in Australia, everybody wants a van. I say we like.
That's what I'm thinking.
Let's get a bike.
Yeah, absolutely.
Far up. That's
Yeah.
much better. And a bed on the back and a pop-up tent.
Yeah, that's
I mean,
right. Yeah.
I don't know how you do that in London. It rains quite a bit, doesn't
We've
it?
got a gene expert on there, FibroScan, the lot. Yeah, it's really good,
That's amazing. So maybe a bike is cheaper than a van, because a van is very expensive, as we keep hearing, and that's one of the impediments. Are there any questions for Sive and James? Just coming behind you with the microphone.
Greg, I work for the Hep C Trust as well. Good to see you up there, guys. I'm always interested in that relationships we're talking about between the peer and the nurse, and that two-way flow of educational information about what each other do and your backgrounds and stuff. The liver nursing teams we work with are absolutely fantastic. I work out in the community as well, but I've often had I've had experience of nurses saying, when doing our degrees at university, there wasn't one module on addiction, and yet a lot of the people that we are treating and supporting, and so what we're finding is a lot more openness about learning what's actually going on for the patient behind their using and getting them out and about, which is brilliant. So I just wanted to ask Syed how, if you had any experience of that before, and how you're kind of accommodating James's experience and how James is kind of like accommodating your experience as well. So everyone's learning, because it is fantastic work.
So I trained in Ireland and we didn't have anything on addiction either. I think the experience that I would have had before joining the team, I worked in the infectious diseases ward in the main hospital. So there would have been, we would have had like the highest majority of patients that were in for a variety of stuff, but would have like addiction issues. That would have been probably the main experience that I had. I think joining Find and Treat, and because it is like peer and clinician led, I think yes, I have the background of a nurse and I have that experience, but like I do feel like these guys, the peers, there's so much more that I feel like I've learned from these guys than I've necessarily.
Yeah, that's right. Yeah, so
I haven't really answered that very well, but
no. So I can just say, so I've come from a drug and alcohol background, working with Louise Hansford for Hampshire. So I used to work in Wessex and in Hampshire and in Surrey as well. So when I'm working with patients, mine's more around harm reduction, looking at criminality, housing, drugs, family, and then looking at that. And then in the past, you might making referrals to drug agencies as well. And looking around that holistic care, and looking at other avenues, support, is there group work, or, looking where they're at. And for me, I find the nurses learn that from me, and I learn more around. So when I went into Find and Treat, I only knew about really hepatitis C, and I didn't know much about TB because I had TB when I was really young. So since I've been working with I've been finding more about syphilis and HIV and Hep B, and gonorrhea, and find out the gene expert machine can do TB and sexual health as well, and can do urine samples. So I've gained a lot of knowledge from Sive and vice versa. Yeah, absolutely, yeah.
I think just going back to what I was saying earlier about the gatekeeping thing, like as clinicians, there often is that idea of like, well, I'm the expert because I've done a degree and I have this experience, but like you kind of need to take that away and just be like, you can learn something from everyone, like regardless of whether they're a nurse or a peer or whoever they are, like there's always something to be learned. And I think it's kind of taking that guard down of like, well, I'm the professional here.
Are you able to bring that back into the hospitals and stuff? I made a note of that, trying to avoid gatekeeping. I made a note of that.
You know what?
This is nothing against any nurses or anything, because we're all like on our own experience and stuff. But I had a liver nurse ask me once, why don't these people turn up for their appointments?
These people,
I'm on the liver
love that.
surveillance. I said, where should we start?
Yeah.
Where should we start?
You know, and I think that's one of the reasons why we're doing this workshop today, is because I think we have to start talking about gatekeeping, and we have to talk about and start. I'm a big believer in modelling. You know, everybody in this room can influence another person who can influence another person. And I think, you know, we can all be leaders in that space. And so I really, really take your point. This whole idea started, Jane and I were chatting one day when you were employing those peers. And I think you said to me, Jane, oh gosh, I don't know quite what I'm looking for. Like these people, the people I've interviewed, they don't really know anything about hepatitis. I said, God, that's the last thing we need them to know about. You know, we can teach them hepatitis. When I'm looking at hiring nurses, I'm looking at people with the right attitude, social justice principles, that belief that they're on a lifelong learning journey, that, you know, they aren't the source of all knowledge. So, you know, I think it is about shining a light on all of these, you know, different aspects of how we can all play that role. Thank you to our panellists. People who don't know me, I have a terrible tendency of going over time. I generally just don't take any notice of the time. But I feel very stressed about the time today. And I've got this thing counting down in front of me, which is aiding that anxiety. So we are now going to somehow break into 3 groups-ish, maybe 6 groups, and we're going to try and have these discussions. So the topics that we're really curious about, and we've been meeting as a group most of the year, talking about the questions that we have. What are the things that you know, because Alex also works in peer nurse partnerships with Peers on Wheels in New South Wales. So, you know, what are the things that we're trying to think about and nut out ourselves? So Alex is going to lead a group discussion or document a group discussion around what does it take to develop a trusted peer nurse relationship? What is the scope of practice issue? And I think that goes really to this point about gatekeeping and about who does what. I mean, you know, James is taking blood. We do have peers in Western Australia who are trained venipuncturists, but, you know, this is not as widespread as it sounds like there are in the UK. So what is the skill mix? What is the scope of practice? How do you have those discussions? And, you know, what can we lean on to guide those? I am going to facilitate a group on practical aspects of data collection, because I think, you know, I've said yesterday at the nursing breakfast, for me, the nursing input into hepatitis C elimination, certainly in Australia, is missing. It's a bit better, and there is data being collected around the world. I'm concerned that our peer colleagues are also not as visible as they should be. So how do we collect that data in a really practical way? You know, you don't want a red cap database and every time you go and speak to somebody, you press go. You know, what does that actually look like? So having that discussion. And then Emily is going to talk about the considerations of, facilitate a group around interagency organisations, interagency collaboration. When you have a peer and a nurse who come from different organisations, what does that memorandum of understanding look like? How do you set that up? So, Alex, use your big voice and try and... How are we going to do this?
I think two tables, and we just kind of like...
Okay, so maybe can I do 2 tables, so that we can, have a bit of a gap. So if everyone can get up, we're going to move around, so we're hoping everybody will have that ability to have a discussion on every topic. But if there's a passion project, there we go. Thank you. Awesome
Thank you so much.
collaborators.
Major exit of people.
I was when I.
Amanda can help me. Yeah, they've both been. We did the training. Like, we all thought we would be able to. And like, we just wouldn't even let them do surveys. Like, doesn't trust them to consent people. I'd probably help me.
They don't work for us, so they're like non-biased,
They just go.
well. Keeping it simple. Let's not overcomplicate things. Governments do that for us. Public health does that for us. They have their questions that they need to answer. And we obviously are contributing data to answer that question. But we need to keep it as clear and as simple as possible, but be very clear about why we're collecting it. And then also perhaps feeding into the interagency discussion around making sure that data sharing is a part of that, so that data can be shared and you can actually talk to each other about that. Thank you. Emily.
Oh, thank you. So we discussed what you need to set up a good relationship or a good partnership, and the three key things that came up was definition of roles and boundaries for the people working for each organisation. There's a lot of discussion around support for the peers, and particularly how do you support peers in starting and orientating and then having some career progression opportunities. And I think the third key one that stood out was how do you get around some of the rules of maybe a service or a hospital-based service that has rigid rules. How do you support someone who maybe doesn't have a licence or has been in prison? How do you support them to be involved in the program?
Thank you. Alex.
So it's a little bit chaotic.
I would never have picked it.
Never have picked it. So I think the key themes that both groups kind of came up with is that there needs to be a lot of, so if we were going to put a PD, which I'm not going to put out there, so position description together, it's not about what clinical skills that people can bring, it's exactly what you were saying earlier, it's about the kind of personal skills, that being trustful, respectful, acting from a place of humility, like being clear that if I'm going to let the nurse listen, I don't know the answer to that, the nurse will have maybe more information. Being clear on how much each person knows, which I think is about the boundaries, but really being supportive. So one of the things I think as a part of the position description and roles is about maybe nurses as educators understanding that they need to just cool down, slow down, and be available and patient for maybe those IT issues, but also to themselves be open to being taught. And that's not always like there's this kind of hierarchy that was talked about, and we need to be really aware of that and have that built into the like culturally appropriate nursing care around patient-centred care was the thing, actually identifying the primary purpose for that partnership. What are we about? What's our vision for this partnership? What are we hoping to achieve? I love that pastoral care was something that the guys talked about as well, and there was also talked in the session, the community leadership session, that health doesn't do it well. We're all kind of victims to vicarious trauma a lot of the time when exposed to people's difficult lives. Our own is going on in the background as well, but here's, I think, really in the thick of that, and that pastoral care from, if it's inter-organisational, that those other organisations are providing that care. If it's health, we need to really look at that and make sure that that's being provided. And that was the adequate psychosocial supervision, which I think is also amazing. Respectful of being in their house, like we're not in our house, which is the big white building with the cross on the top of it, but we're in their house, in community, and to be mindful of that. And look, we kind of did a little quick delineating, not the position roles, but the actual roles we do, non-clinical versus clinical. And it turns out most of the clinical skills can be done by both partners, and they can be taught skills. But then there is stuff that's in the non-clinical about being someone with lived experience and sharing that story that the nurse may not be able to. There's nurses who can share that experience and may and do at times, and others that might not. Also being adaptable. I mean, we talked two organic processes at the start of the programs. At the start, we're both very organic how they started, and so knowing, okay, that's not working, let's drop that, let's try something else now. And
Thank you. Thank you so much from the bottom of our hearts for participating in this session. We hope it's the beginning of a broader discussion. As a nurse and as a multidisciplinary team of